Good morning, and welcome to our next lecture, Geriatric Psychopharmacology and Neurocognitive Disorders. All right, to get us started, we're going to go over the geriatric psychopharmacology kind of principles, rules, etc., and then we'll go into the neurocognitive disorders. All right, so to get us started, pharmacological interventions later in life require special care. And if we think about that, as we age, our body begins to slow down, right? So our metabolism, our excretion, so we're more predisposed to having adverse events due to drugs, more adverse issues such as constipation, urinary retention, even delirium and cognitive dysfunction, and even antihistamine type effects such as more sedation and even postural hypotension. These effects not only pose a risk for elderly just to have, say, example, with orthostatic hypotension and being more sedated, but also putting them more at risk for falls and even fracturing themselves. So increased susceptibility to adverse effects in elders may be a result of the pharmacokinetic and pharmacodynamic changes associated with aging. And this is what I was just mentioning. So there's diminished glomerular filtration, changes in density and activity of the target receptors, reduced liver sizes, hepatic blood flow, and decreased cardiac output. So things begin to slow down, okay? So it's putting us more at risk for adverse effects and toxicity. Now, illnesses that also affect many elderly people, such as diabetes, can also further diminish the processing and removal of medications from the body. Polypharmacy, oh my goodness, and how many people as they age that we hear the word polypharmacy in many prescriptions, right? So polypharmacy and associated risk of drug interactions adds a whole nother level of complexity to the pharmacological treatment in older patients. And yeah, if you think about that, and sometimes they'll walk in and they have a whole Walmart bag full of medications, and you're like, oh, what is this one for? Oh, this one, I'm not really sure. I just know I take the blue one in the morning and the yellow at noon, and I think I have a little orange one at night. And that can be quite confusing, not only for the safety factor of taking them correctly and which ones are interacting, or if especially if a pharmacy has changed a medication, they've kept an old bottle and they may be taking two of the same medicine. But even chemically interacting, the more medications on board, the more safety interactions and things we have to watch for as prescribers to making sure we're not causing more harm to our patient. Poor adherence to treatment regimens. Maybe it's due to cognitive function, confusing the drug regimens, maybe a lack of motivation or even insight with their psychiatric disorder. And so that can also put a more of an obstacle in safe and effective pharmacological treatment. Psychotropic medications are not as extensively studied in elders, also as younger individuals, with those without comorbid medical illnesses. So, with not having enough studies or really research what we pose, what we think this is going to happen, we do these clinical trials that most of these individuals are without these comorbid medical illnesses, or as many, right, and maybe a younger body. And so what we think are the normal side effects of medications may not always be exact for this age of population. So when it comes to antidepressant prescribing in geriatrics, geriatric patients are at high risk for relapse for both recurrence of the depression and anxiety. In older adults, SSRIs still remain the first-line antidepressant, okay? And they do. They have a long-acting, even as we talked about with children and adults. There is a lot of clinical research with high efficacy, ease of use, good tolerability, and relatively safe. And I also think when we're covering geriatrics, just as we just covered pediatrics, the geriatrics and pediatrics remind me both of the same. Start low and go slow. And so SSRIs, of course, being that class of antidepressants that are least likely to have the side effects and a lot less side effect potential, and generally be more tolerable as well. Older patients' SSRI starting dose are typically 1/2 of the minimal efficacious dose, and the dosage is usually doubled after about a week. So, here there was statistics that used to say 1/3 to 1/2 the dosing. Now it's 1/2 to 1. Really kind of depends on the medication. Maybe if you're looking at Zoloft, you still may be able to start at 50 milligrams of Zoloft, just as you would with an adult, versus I know a child we talked about maybe even starting at 25, depending on the age of the child. But that might be one that you could start as normal. When it came to Lexapro, again, you could probably start 10, absolutely no issues. Some people will start 5. Celexa, same thing. You might see some people start at 10. more of a pediatric dose, and you have those that start at 20. Celexa, more commonly because of the QTC prolongation risk, though, we do tend to start it more of half the dose, and so you're going to see it usually about 10 milligrams initial, starting with the elderly. All of the SSRIs can be administered in a single daily dose, though, except Luvox or fluvoxamine, which should be then given in 2 divided doses. And that's going to make it a little easier, too, as we just talked about. Maybe if there's some cognitive functioning here, we don't know what their support system is with their family, and being able to help them with their medications, that can pose an issue if there's more than one daily dosing. When it comes to SNRIs, so according to our text and our information, with SNRIs, there are more cardiovascular effects or risk with SNRIs with the elderly. SNRIs can cause, or not only cause increase in blood pressure, but also orthostatic hypotension, EKG changes, arrhythmias, and even death if you were to overdose. Now, they may not be the first line, but, if they have failed SSRIs, it's still a good option. And I will still say, just with working in geriatric inpatient units, in my experience, we kind of had almost a cocktail, per se, that we would use. And so we often use Cymbalta, which was an SNRI, of course, duloxetine. And, if those individuals that have those melancholy, low energy, low fatigue, no stimulation, seem like they've kind of given up on life, not into wanting to do their therapy or engage with family. You just kind of look at their symptoms. We often would go with that, and hitting that norepinephrine almost seemed to kind of cognitively stimulate us a little bit, though. And the geriatric psychiatrist that I work with, his also belief was, a lot of times as we age, there's also different pain factors, and that was just one way he could kind of help with their pain, and as well as their cognitive stimulation and their depression. So, again, yes, do we have more risk? Yes, but as long as you're watching your patient, you're taking care of them, especially if there's been previous failures, SNRI may be a good option. Other medications such as bupropion, remember it's Wellbutrin, or mirtazapine, which is Remeron, can be also used in older patients, usually actually more favorable due to a lower side effect profile. Again, that Wellbutrin is going to hit and be more stimulating as well. And then that mirtazapine, especially if you have those individuals when they're starting to slide into more of the early stages of dementia too, or even moderate stages where they kind of forget to eat, and they're not as hungry, they're losing weight. That may help to stimulate their appetite, as well as if they're having issues sleeping. Remember, we can use mirtazapine to help them sleep with their depression and their appetite. Can be a good option to have on. Other antidepressants such as the TCAs are not favorable in geriatrics, okay? The tertiary ones such as amitriptyline, clomipramine, doxepin, and imipramine all can cause significant orthostatic hypotension anticholinergic effects. They can be very, very drying, so the urinary retention and things are going to get worse, risk of falls, risk of more having cardiac events. Where the secondary, there are 2 of the TCAs, desmoprine and more or less so that I've known more, the nortriptyline, that has been used more often and is considered more safe if you have failed SSRIs and SNRIs and you need something to assist. The nortriptyline can be an option. It does have a lower propensity to cause orthostasis and falls, and a more modest anticholinergic effects. It's not quite as drying. MAOIs, of course, rarely used. And this is out of your text, really, in elderly, but reality is rarely used at all, right? As we talk about remembering trying to remember the tyramine-containing diet and how to avoid certain medications, it just becomes more difficult. So antipsychotics in elderly use, atypical antipsychotics are being prescribed more as first line for the treatment of psychotic symptoms, okay? Studies are beginning to support the efficacy of these agents are in the treatment of late life schizophrenia and late onset psychosis. Okay. However, their role in the treatment of behavioral and psychological symptoms of dementia is still being questioned. Okay. So here's the thing I want to say when it comes to antipsychotics, and it's going to kind of come to this next blue little shape here. You're going to have a black box warning on your antipsychotics, okay? Your conventional, or otherwise known as typical or atypical, your newer ones, you're going to have that black box warning of, hey, this can further reduce cognition, worsen, especially if there's a diagnosis of dementia. So it's kind of a hit or miss and something that you're going to have to work with family, and it's very, very important in the treatment of dementia and behavioral issues as well, is that when we're using antipsychotics, you got to outweigh the risk versus the benefit. So talking with the family, letting them know, hey, grandmama is doing this and she's hitting, spitting, cursing, screaming, crying, all these things are happening. Feels like her feet are tied with strings, she's walking in sand, there's babies crying, do we want to put on something that may reduce those hallucinations, delusions? However, this may speed up, unfortunately, great to say it, but speed up our decline as well is very possible. And it's kind of really, what does the family want as far as quality of life for the time that your family member has remaining? What kind of life do we want to have? Can we deal with these type behaviors and avoid medications such as that and have a longer time spend period, or have a better, more controlled quality of life, more sleep, less irritation, anxiety, and just may not have as much time with your family. So really, really making sure that you spend time with patients doing education. But that's where the whole however part about not really completely understanding, okay, with dementia, are still being questioned in use, because there is that warning there that makes it a little bit more difficult, okay? So you see that blue box basically is just saying, again, FDA warned a nearly twofold increase in the rates of death in patients with behavioral and psychological symptoms of dementia when treated with atypicals when compared to a placebo, okay? And again, both conventional and atypical antipsychotics. Now, although, atypicals there's less risk for the EPS and those type movement disorders with atypicals versus the older conventional ones. And they actually may cause a little less likely chance for falls, so that's good. But then with those atypicals, remember they're more risk for metabolic syndrome. So we do have more risk with elderly using atypical antipsychotics for more cerebrovascular events, venous thromboembolisms, and pancreatitis. So we need to still be alert and getting those lab works every now and then, at least every 6 months to once a year, depending on how long and stability of the drug, so we can make sure our patients are okay. Now, mood stabilizers. Mood stabilizers actually, just in working geriatrics, are used very prominently. Yes, the antipsychotics you're going to see as well, but there's coming obviously more and more push in working with geriatric psychiatrists who push more of the Depakote use and the lithium use when it comes, because as we talked about in prior when we covered mood stabilizers, there is some neuroprotective research and effects coming out with both lithium and valproate, or otherwise known as Depakote, and so that it may actually be able to help prolong these incidences, these damaging to the brain caused by the disease process in itself. So we do use these for agitation, okay, in dementia. Maybe also calming down if they seem erratic or behaviors kind of on and off, and there's pacing and walking and consistently maybe combative with family, very anxious as well. We can use these medications to kind of help to stabilize their mood. Now, we still don't have, there's no consensus exactly, though, if we're using this as far as bipolar. Which drug are we preferring first as far as a first-line mood stabilizer in older patients with bipolar or mania? That has not had a consensus of which drug is, hey, this is going to be the one that you need to use first line. But we know that they are still used. All right, benzos. So benzos we already learned about a lot, which is pretty much when we covered anxiety issues and benzodiazepines. There was that big push that we use these very sparingly anyway, very temporarily, and we have to be very mindful because of the abuse factor. Well, in elderly, those same things still apply, but then we also have to even consider, hey, we may be at more risk for falls and hip fractures, as well as, because it is settling down and kind of, it's a CNS depressant, it's depressing the central nervous system, then we have more likely also for cognitive impairment and even causing traffic accidents, okay? So if you've got elderly people who are still driving, need to keep that in mind. Now, there may be short-term relief. This may be used in the hospital if you've worked in the unit, things like that, or in the emergency room for short-term initial injection maybe of Ativan to calm them down. But you want to find an alternate long-acting medication that's going to work better so they don't have these risks of staying on benzos long term. Benzos with long half-lives, such as the Klonopin or diazepam, Valium, should be avoided. Even several drugs with shorter half-lives, such as the Xanax, Triazolam, Midazolam, Zalpulon and Zolpidem, like Ambien, the sleep hypnotic drugs, because they go under the hepatic metabolism of C1P3A4. There are still different interactions and age-associated declines associated with those. So you still, again, have to be very, very mindful, okay? And if you've got even a short acting and they get up to use the bathroom in the middle of the night, they can still stagger off, have a fall, fracture a hip, and so we just need to be very, very mindful. One short acting benzo that you will see most often, as I think we mentioned prior, is lorazepam. We had mentioned this in our previous lectures that lorazepam is seemed to be used more often. There is no active metabolites and has an acceptable half-life that does not increase with age. There's not as many, or I guess does not subject to drug interactions, okay? There are also very small doses available, 0.5 milligram pills, and even upwards. I think we even had protocols back when I worked with one psychiatrist on the geriatric inpatient floor of like 0.25. Very minute baby doses, just something to be able to be calming, but not completely sedate, maybe calm down in the moment when they were having a fit or a flare-up. Maybe during the sundowning times, but didn't want to have to completely sedate them all afternoon when family began to come visit, or also again increase those risks of other symptoms or side effects from the drugs. All right, now going into neurocognitive disorders, okay? So let's start here first. So let's start with delirium. And I want to make sure that we understand delirium versus dementia, okay? So delirium, acute decline, both the level of consciousness and cognition with impairment in attention. Other neurological symptoms with delirium include abnormalities of their mood, perception, and behavior. You can also have tremor, nystagmus, incoordination, and even urinary incontinence. Here's the key word here, right, though? Acute, okay? The now, here and now, decline. This is more of a sudden onset and decline, okay? Now, precipitating factors can be certain drugs. It may be the sedative hypnotics, narcotics, anticholinergics drying you out too much, alcohol withdrawal, which that goes back into that Wernicke's encephalopathy and Korsakoff's we discussed previously. It can even be steroids. Sometimes people on steroids will have a change in mind onset. Neurologic diseases such as stroke, meningitis, intracranial breathing, even infections, hypoxia, shock, anemia, fever, poor nutrition, dehydration. After surgery, could be anesthesia, okay? Could be just after surgery itself and what went on, the factors in cardiac and orthopedic surgeries. Or maybe it's environmental, the use of restraints, pain, emotional stress, prolonged sleep deprivation. All these things can lead to delirium. So here's some factors if we compare one-on-one, vice versa, side by side, delirium versus dementia, okay? Because it's going to be key that you can diagnose and properly diagnose which one is which because the treatment's also going to vary as well, okay? So delirium, rapid onset, hours to weeks in duration, okay? Now, the quicker we can intervene with delirium, the better chance. The more prolonged, the more likely of death, okay? The more quickly we can intervene with delirium, the better, all right? You have fluctuating levels of attention, impaired recent and immediate memory, incoherent speech, could be slow, could be rapid, disorganized thoughts, frequent disruption in their sleep-wake cycle. A lot of times it's maybe up during the night, sleeping during the day, just changing in their pattern, kind of like a baby's kind of offset on their schedule. Reduced awareness and hypervigilance, or maybe even reduced vigilance. There's just not even any jump there if someone were to come up behind or open the curtain, just no movement at all. Now, dementia, it's more of a gradual, slow onset, okay? Usually there's more stability in the time and the decline that you're seeing with dementia. There's months to years in duration, okay? Attention's pretty preserved. For the most part, they can pay attention, and depending again on the stages, but attention is not fluctuated as much as like with delirium. Impaired remote memory, difficulty finding words, fragmented sleep. Maybe tonight they slept 2 hours and they had trouble going to sleep, or trouble staying asleep, or was up 2 hours and back asleep and up and slept for 4 hours, or one night we had a great night and the next night was horrible. Impoverished thoughts, just not completely fully thinking through sometimes thoughts, or a lack of thought. Unchanged awareness, still are aware of the surroundings for the most part, but not as suddenly changed, and usually pretty normally alert. Again, depending on your cycles, could still be alert, just maybe confused and not know what day it is or where they are, and later stages not remember being able to recognize people. So how do we treat the delirium? The goal, obviously, is we've got to treat the underlying cause. Is this because of steroids? Is it because of a urinary tract infection? Is this because of renal failure, dehydration? What is the cause? First, find what is the cause, okay? Then we can go about the treatment, because the thing is, if this is true delirium, then, and I've seen this unfortunately so often where I've had patients, they'll want to come up and they'll call for a psych consult in the emergency room. Unfortunately, even sometimes before they've even had vital signs done, come down to do a consult, and the patient's got 103.5 fever and positive for urinary tract infection. Again, we need to treat the underlying first. Treat the urinary tract infection, and if the confusion and the change in behavior and mood goes with it, then obviously this was delirium. If it continues, and if there is a history, maybe this is dementia. But you've got to treat the underlying cause, okay? We also need to provide physical, sensory, and environmental support. Treat if there is psychosis and insomnia along with delirium. Certain medications we can use for that is Haldol. Of course, can be given PO or IM. If you're working in a unit or emergency room, most often you're probably hearing the Haldol. And your book did not say Ziprasidone or Geodone, but a lot of times Geodone will also be using, given about 20 milligrams of Geodone injection as well. Risperidone, olanzapine, quetiapine, and lorazepam, again, there goes that Ativan, can all be used as needed to kind of help with these symptoms of psychosis and insomnia, depending on the patient. All right, now, so we talked about, so delirium is very quick onset. Usually there's some kind of underlying cause. We've got to treat the underlying cause, and the delirium should get better, okay? On the reverse side of that, we have dementia. Remember, slow, gradual, let's just say it up front, and we all know there's no treatment, right? We can treat the symptoms, but just like most other psychiatric illnesses or disease processes, okay, there is no absolute treatment. We're managing these symptoms, okay? So someone is diagnosed with dementia, or the DSM-5 kind of recategorized, renamed it. Instead of cognitive disorder, they've called it major neurocognitive or mild neurocognitive disorder, with or without behavioral disturbances. So without meaning we've definitely got changes in our functioning, our cognition, but not having maybe psychosis, anxiety, agitation, irritability, anger, etc. Those are with the behavioral disturbances, okay? Now, obviously with behavioral disturbances, we're going to be treating that more. We may need to pull in those atypical antipsychotics and then other medications to help resolve the issues. For diagnosis, though, if we're actually diagnosing somebody, and yes, are there imaging studies we can do and CT scans and changes of the brain, and this is atrophied and general aging changes versus dementia changes. And remember, when we're diagnosing for Alzheimer's, really to be able to actually see those neurofibrillary tangles and plaques, technically an autopsy of the brain, what we think we can see some changes. We have some diagnoses. Now they have genetic markers they're trying to run and develop for treatment for Alzheimer's. But really getting to that knowing of his Alzheimer's kind of as a collective, putting all the pieces together. So your person must have, your patient must have a decline from their previous level of performance in one or more of the cognitive domains, whether it's learning and memory, their language, executive functioning, complex attention, perceptual and motor skills, and social and cognition. There has to be a deficit in independence in everyday activities, such as paying their bills, maybe managing their own medication, possibly even in beginning where ADLs, being able to have a hard time bathing, leaving the stove on when cooking and not being safe. I always share the story when I talk or lecture with students when I get to dementia chapters, is my husband's grandmother had Alzheimer's, and she actually, they had gone camping, and she thought, bless her heart, that she'd grab the cooking spray, Pam, to make biscuits one morning, but what she did fail to really pay attention or take time is grabbing the off bug spray. So needless to say, when the biscuits were done, they had some off bug spray tasting biscuits, and knew pretty quickly right off what had happened. Now that was very, very early stages. And that can happen, I guess, with anybody as an accident, but I just remember that so specifically. You know, we kind of laugh about it sometimes, that having off bug spray biscuits. Cognitive deficits are also, they cannot be explained by another mental disorder, just like others. Is this really, do we have a decrease in our cognition because of our depression, because of our schizophrenia? You know, many mental status examination, when they do those upon admission, emergency room, etc., you know, scores out of 30. And if there's less than a 23, then there may be signs here that, we may have some cognitive deficit, okay? Now, however, when you see true psychosis also come in the door, that mental status exam may not be great, okay? I have seen very, very depressed and also very psychotic patients, maybe score 16 or 18. Does not necessarily mean they have dementia, okay? One of my preceptors a long time ago taught me that, how do you know the differentiating between if it's psychosis and dementia? And if you think about it, your schizophrenic patients are usually still oriented to time, okay? They know what day it is, they know what time it is. For the most part, they know where they are. But orientation, they're usually oriented, okay, to person and place and time, versus dementia is not always. They may have a change in their speech and their attention, and you know, bunches of ideas they're telling you are a specific delusion. Absolutely, it's possible, but they're usually still oriented. Okay. All right. Just for you, again, for the visual learners, sharing a little mnemonic for the 5 A's of Alzheimer's. So there's anomia, or an inability to remember the names of things. Amnesia, having memory loss, and again, that unfortunately progresses as time goes on. Apraxia, misuse of objects. I had a patient, bless her, that when I was working rehab, who she had the diagnosis of dementia, but she had been on the Geriatric unit. She'd fallen and broke her hip. She had to come back down to rehab. We kept her toward the front with the nurses station, and I walked in at one point, and of course she was already undressing, and it's like, no, let's keep her clothes on. Something about wanting to undress seems to be a recurrent trend. And then, you know, one day was in there, had walked out, coming by to do safety round checks, see how she was doing, and she had pulled her trash can by her and some of that Dr. D's mouthwash, and she was taking it and rubbing it on her skin as lotion. Now, trying to get that back from her, that was that was interesting. You know, you do the best you can, you talk and try to educate, oh, that's not lotion, and go from there. But, you know, misunderstanding, that's not a lotion, okay. Agnosia, inability to recognize familiar objects, and unfortunately over time also being unable to recognize even themselves in the mirror. Aphasia, inability to be able to express themselves, and this can become very, very frustrating because knowing the word you want to say and you're not being able to get it out. Etiology. And let me say something here too. Let me go back for a second. That is one of the things, actually, and you'll see more likely, there is earlier and more chances of risk of suicide and depression when it comes to the early stages of dementia, where people are still there enough, have their mind enough that they are aware, they are alert enough to know that there is a decline, that they have the diagnoses, and they are very upset and want to try to hide it from their family. And a lot of times will actually isolate from family events and things because they don't want family to notice, that they know that they're beginning to get lost, can't find their car to the grocery store, turning on the wrong street, forgetting things, losing things, misplacing things in the house. Very subtly starts to creep in more and more. And they do. This is where it's knowing that your mind is declining, trying to put yourself in their shoes. That's a hard thing. All right. So etiology. There are degenerative types or causes, Alzheimer's, the Parkinson's or Huntington's, even Lewy bodies, having, of course, the Lewy body actual places on the brain. Frontotemporal dementias are otherwise known as Pick's disease as well. Psychiatric, pseudo-dementia, depression, cognitive decline later in life with schizophrenia, tumor, trauma, cardiac issues, vascular, anoxia, as we talked about, stroke, cardiac infarction. There may be a lack of oxygen to the brain for a time period. Different drugs, toxins, maybe over time, doing hard chemicals or drugs. There is alcoholic dementia over time. Demyelinating, multiple sclerosis. All these are types, causes of your dementia, of your major neurocognitive disorder. So how do we treat this? We talked about delirium, and obviously we've got to treat the underlying cause first. Well, first step is you still need to make sure that you verify the diagnoses. And did you do a mental status examination, a history and physical, gather all of your information that you needed? You can run a CT scan, see if there are changes in the brain to help you confirm your diagnoses. There may need to be psychodynamic interventions, educating the family, being a support system. What does this mean safety-wise? Does this person need to still be behind the wheel driving a vehicle? Making those type education decisions. Do they need to be living alone? Do they need sitters? What type of support do they need? And then we can also use drugs. Now, this is very controversial because yes, can we use the benzos for sleep and anxiety and antidepressants for depression? Yeah, absolutely. Antipsychotics, delusions, hallucinations, all this makes sense, right? But this last one, this last bullet, this is what's controversial. Cholinesterase inhibitors to treat mild to moderate cognitive impairment. Okay, and then of course we've got memantine, we'll talk about in just a moment, that's for moderate to severe. What makes it controversial is you have some who believe if your mind is going to continue to decline, if the disease process is only going to get worse, and there's no treating it, why use the medications and have more likely a risk of side effects? And I mean, if you think about that, But then there's also that side of, yeah, but if we have these medications that maybe give grandmother or grandpapa an additional 6 months, 6 months maybe of more clarity, or maybe just slow the disease process down just a little bit. We know eventually it's going to happen. Eventually they may pass. Eventually this is going to get worse. But to have those 6 months, or to have a few months of a little bit more clarity, is it worth it? So you've got these, and that's another thing where you sit down with the family and you talk about the risk versus benefits of the medication, and you come to that conclusion that, what is going to be our better option? What is going to work best for our patient? So, if we look at the cholinesterase inhibitors, okay, and memantine, otherwise known as Namenda, all right? So the cholinesterase inhibitors, they reduce the inactivation of the neurotransmitter acetylcholine, thus potentiating cholinergic neurotransmitters and in turn produces the modest, here's the key word, modest improvement in memory and goal-directed thought. Now, I will tell you different texts may vary. Most textbooks will vary anywhere between 3 to 6 months of maximum benefit with any of these drugs, okay? So beyond that, there is no more benefit, okay? So we may have had 3 additional months of, wow, Grandma actually seemed like she was a little more on point, remembered things, made more sense on the phone today. Wow, this is great. Eventually, again, that will decline. Maybe it's 6 months worth of actually being, again, slowing down memory issues, being able to focus better, but eventually, again, it's still going to decline. Now, these type medications are donepezil, otherwise known as Aricept, rivastigmine is Exelon, galantamine, which is Rimonil, and then the Tacrin, which is Cognate, which we don't actually use anymore due to the hepatotoxicity and having to monitor lab work and etc. So that's very, very seldom used now. Memantine, otherwise known as Namenda, is not a cholinesterase inhibitor, but it produces effects by the blockade of the N-methyl deaspirate or NMDA receptors. And this is actually used more for your moderate to severe stages. Okay, and we'll talk about that a little bit more here in just a second. So our cholinesterase inhibitors are adverse reactions that we can have. Okay, nausea, vomiting, diarrhea, like we always talk about. That's pretty much on everything. Dizziness. Okay, muscle cramps are possible with the donepezil and it was Aricept. Insomnia, which I always think is the most interesting thing because they actually recommend that you take that at night. And when you had a geriatric psychiatrist, would actually prescribe that about 5 o'clock with supper. It's always 5 o'clock with supper. I'm like, wow, but insomnia is a possibility, but maybe again, the way that it's peak time is that was what they best recommended, is to giving at night. So then the day we were more cognitively aware of things. Aricept is actually contraindicated with those with AFib, okay, due to the bradyarrhythmias and the changes in our EKG, possibly from the Aricept. So we need to be very, very mindful, making sure that you're educating and getting a good thorough history on your patient before use of Aricept. Weight loss is possible, again, also with donzapil, and then as I talked about the hepatotoxicity with the Tacrin, that we hardly use the Cognix anymore. So dosing schedule, if we're going to do the donzapil or the Aricept, start 5 milligrams each night if tolerated, then increase to 10 milligrams thereafter, okay, unaffected by meals. So again, I found that very, very interesting that I always saw it at 1700 with dinner to be given, and I'm not sure why, but if that's why they're more tolerated and prevent the GI effects, and that's the way they prescribed. Rivastigmine, or otherwise known as Exelon, initial dose is 1.5 twice a day for a minimum of 2 weeks to a target dose eventually of 6 milligrams per day, taken in equal doses. Now, the risk of GI upset is reduced by food. There's also an Exelon patch. So if you have those who are not compliant with medication, spitting out tablets, don't want to take medicine, they may be more likely to tolerate or be, I guess, more compliant using a patch version of the medication. Galantamine, initial dose of 8 milligrams per day, with a minimum up to 4 weeks, then can increase based on their tolerability, with a suggested dose range of 16 to 32 milligrams given in twice daily dosing. And this was interesting to me. The higher dose is actually tolerated better than the lower dose. So again, once you've worked your way up, the higher doses actually don't seem to be nearly is anything to get used to as much as the lower dosing. Memantine or Namenda, food actually has no effect on absorption, so that's good too. Now, Namenda you're going to see usually given in twice daily dosings. You're going to usually see it with morning and supper, but food does not necessarily have an effect on the absorption. Namenda may protect cells against excess glutamate by blocking the MDA receptors associated with abnormal transmission of glutamate, and then allowing physiologic transmission associated with normal cell functioning. So there may be some actual protection here with declining, and it's given more for the moderate to severe state or stages of the disease process. Adverse reactions: dizziness, headache, constipation, and confusion. Not recommended with those with severe renal impairment. Unusual dosing, we start about 5 milligrams a day with a goal of increasing up to 20 milligrams per day in divided twice daily dosings, and can actually increase by 5 milligrams each week depending on the tolerability. Now, I'll see more and more again, it goes back to when everybody has different prescribing, there's different beliefs. I think each of us, even in your course, those of you already practicing or those working as registered nurses now, probably see that on their units. And a lot of times you also see what people are comfortable with and cocktails and things that they believe per se, that they have very frequent of the same dosing and prescribing. And we get in our comfort zone. But just knowing, these drugs are there, they are possible. I have doctors who I've seen use these earlier onset, even before when we're just on that borderline between mild and moderate, they're going ahead and adding Namenda because of their beliefs for the protection factor. I think there's still more research to continue to come out there, but that may be something if the family is okay with that and they're on board. In the early stage of the patient also is aware and they want to try something for their memory. It's there. Definitely try it. Just ultimately make sure that you're educating again these families and the patient. This is a temporary, right? This is maybe delaying, maybe small improvements. Eventually, the mind is still unfortunately going to decline until we find a cure. All right, this was a very short lecture. So I think I'm right about 38 minutes now. So this is my reference. It came out of your SODIC today. Again, you could also refer to your stalls as far as further dosing. There wasn't very many drugs to really cover in this chapter, so pretty straightforward. If you have any questions or concerns, please always, as I say, reach out to me, send an email, make a post in this for this lecture discussion. And as always, also jump in the discussion boards this week to see if you can learn a little bit more from your peers. Hope you all have a wonderful week, and I will see you soon. Thank you.